Assalamu alaikum, ladies and gentlemen, and very good morning. I am Dr. Muhammad Shehzad, Assistant Professor Neonatology, working at University of Child Health Sciences and the Children's Hospital, Lahore. It is a privilege to welcome you to the first scientific session of Neocolloquium 2026. Let me introduce our chairperson for this session, Professor Major General Salman Ali, Hilal-e-Imtiaz military and presidential gold medalist, is a distinguished neonatologist. He has held senior leadership roles including Dean and Principal of Army and Fazaiya Medical College, and served as Counselor and Senior Vice President of College of Physician Surgeons, Pakistan. Sir, please. Professor Amin Jan Gandapur is a senior pediatrician and consultant at Northwest General Hospital, Peshawar. He is the chairperson of Research Division of Pakistan Pediatric Association and leading the National Child Health Research Initiative to strengthen the evidence-based policy and practice across the Pakistan. Sir, please. Professor Brigadier Dr. Talal Waqar, working as Head of Department, Military Hospital, Rawalpindi. Sir. Dr. Hafiz Anwar, Head of Department of Neonatology at Quaid-e-Azam Medical College. Now I request Major General Professor Salman Ali to, sir, please start the session. Thank you.
Okay, thank you very much. We welcome you to this first session of the NEO Colloquium, and I welcome my co-chairs. We would start the session straight away by we'll invite our first speaker. So I'll request Brigadier Talal to introduce Professor Haque, our first speaker.
Thank you very much, Ji. It's rather a great honor for me to invite one of the faculty members of this place and a person who's been absolutely pioneer in steering neonatal health in Pakistan. Whatever progress has been made in last 2 decades, I think we all owe it to Professor Khalid Haque for everything. Sir, it's rather an honor for me to invite you. I've been his registrar also, so thank you very much, sir, for coming to this place and enlightening us on everything. So very kind of you.
Slide. Right. Bismillahirrahmanirrahim. Assalamu alaikum, chairpersons, ladies and gentlemen. It's a great honor to be the first speaker, and thank you, Talal, for those words, which I don't deserve, but there you are. That's what I'm going to review neonatal dysglycemia. I have no conflict of interest and nothing to declare. The question is, why should we be talking about dysglycemia? Oops. The reason why we should be talking about dysglycemia, it is one of the most important metabolic events during transition from intrauterine to extrauterine life. It causes preventable harm and may impact on lifelong neurodevelopment. And that's the key, that dysglycemia can cause lifelong neurodisability. So the objectives in the next 20-25 minutes are the following. I want to define dysglycemia. It is an unresolved problem for the last 100 years. People have been trying to define what dysglycemia is. With apologies to the honorable chairs and the senior members, I'll just mention basic physiology of neonatal glucose hemostasis, risk factors, etiology, clinical manifestations, and then talk a little bit about the marked inconsistency in screening and monitoring practices of dysglycemia. I will also highlight to you the limited consensus in the management strategies. I know there is going to be a breakout session on the management of hypoglycemia, but I am not going to go in great detail, but I'm going to tell you the lack or limited consensus in management of hypoglycemia. Most neonatologists think hypoglycemia is very straightforward. Unfortunately, after 52 or 53 years of doing neonatology, I don't think it is that straightforward. And then I'll talk about the critical knowledge gaps. So let's start to define what dysglycemia is. Start from the very basic. Hypoglycemia. Important message is hypoglycemia is not a number. A blood glucose level that is inadequate for brain energy requirements, so-called neuroglycopenia. The problem is, we do not know what is the level or duration of low glucose that causes neuroglycopenia. So how do we diagnose hypoglycemia when we do not know when neuroglycemia occurs, glycopenia occurs? What about hyperglycemia? Exactly the same. Not a number, but refers to an imbalance between glucose production, utilization, and regulation. Problem? We do not know at what level of glucose this imbalance occurs. So again, we have a problem. We do not know. If I was to ask the audience what is hypoglycemia, except for Junaid, I think everybody will give you a number. If I ask you what is hyperglycemia, everybody will give you a number. But as I have defined hypo and hyperglycemia, there isn't a number. We do not know the exact number, and that's a big problem. And therefore, various researchers, various authorities have tried to define hypoglycemia. And it goes from 28 to 60. Look at the variation. So some people define hypoglycemia at 28 milligrams, and some people define it at 60 milligrams. These numbers are based on opinion rather than robust data. So there isn't a robust data. People have opinion, and people define it according to a number which they choose. We have chosen, this is our policy, but this may not be your policy, and that will be absolutely correct. Our policy is the operational threshold is 36 to 45 milligram per deciliter. You can argue, you can question me about that. Why did you choose this number? And I might be able to give you a soft answer, but not a robust answer. You can choose another number, and that would be equally valid. What about hyperglycemia? Hyperglycemia varies from 125 milligram per deciliter to 270 milligram per deciliter. What a huge variation depending on who is reading what, who is defining how, who is defining when hyperglycemia occurs. There is again no consensus, and our operational threshold is 150 to 180 milligram per deciliter. So why do guidelines differ? Which number is right? I pause here for you to think. Which number is right? Since neonatal glucose physiology and brain vulnerability are broadly similar, and there is similar fetal neonatal metabolic transition, then why different numbers? And there are some endocrinologists sitting here in front seat. They might be able to answer that. Why different numbers? I raise that question to you. All of you are either in training or trained neonatologists, and I ask that question, have you ever thought about it? Why are there different numbers? The reason is the differences are epistemic, not biological. Guidelines differ not because babies are biologically different, but because the evidence, measurement, and assumption we make and believe are different. So it is the problem is with us and how we try and define hypo or hyper or dysglycemia. The problem is not with the babies. We tend to think the problem is with the babies, but that is not true. The problem lies with us. Okay, let's move on. So how frequent is dysglycemia? Obviously, as I showed you, that there was no consensus on definition, so the frequency will depend on the definition you use. If you use 28, you will have a different definition. If you use 63, you will have a different definition. So it all depends on what definition you use. So when you say the incidence of dysglycemia in my unit is X, it all depends on what definition you are using. It may be different in my unit, it may be different in your unit because I have used a different definition. So the reported incidence of hypoglycemia is between 5 and 15% overall. But if there are risk factors, it goes up to 50%. But that is not important. What is important, I want to show you, is the symptomatic is only 1.3% to 3%. Most of the hypoglycemia is asymptomatic. So what we are doing when we treat hypoglycemia, we're only treating about 1.3 to 3% of cases. We are missing 97% of our cases of hypoglycemia, if you're talking about hypoglycemia. Hyperglycemia, on the other hand, is 20 to 35%, but it is mainly in extremely preterm infants. The infants who are less than 27 weeks. Here, the incidence goes up to about 35%. Now, I know that you may not be involved in caring for babies under 27 weeks, and so you don't see hyperglycemia that much. But if you're really, truly looking after dysglycemia, hyperglycemia is a problem of very extreme prematurity. Now again, Talal, with your apologies, if I can show some basic physiology. In utero, there is a small gradient between the maternal glucose and the fetal glucose. So there is a diffusion of sugar from the mother to the baby. So what happens? Well, the baby does not, the insulin does not cross the placenta. So mother gives the glucose, but not the insulin. So the baby has to produce insulin. And therefore, if the sugar levels are high, baby has to produce more insulin. And this process continues causes a beta cell hyperplasia, and this process continues for 24 to 48 hours, or even sometimes longer after birth, once you have cut the cord. What happens when you cut the cord? The placental energy source is cut, so the baby, there's a huge metabolic shift and switch. The fetus starts to find, where can I get energy from? So the fetus gets energy from gluconeogenesis and ketogenesis. And that, to generate energy from gluconeogenesis and ketogenesis, takes time. And that is why you get hypoglycemia in the first 24, 48, or 72 hours of life. There is no magic about it. It's basic physiology. So for my younger colleagues, if I could just summarize that, there's maternal glucose is high, it stimulates the fetal insulin, there's hyperplasia of fetal pancreatic beta cells, you get fetal hyperinsulinemia. Once you cut the cord, the baby is delivered, and you get transitional hyperinsulinemia, which continues for the lower glucose threshold. Because the energy source after birth is high, baby gets hypoglycemia. So I hope the basic physiology is very clear. I've tried to make it as simple as possible. But that is what it is. So the next question is, why? What are the reasons why a baby gets hypoglycemic? The most common reason is the delayed or failed transition. Baby does not transit as smoothly as it should. And that leads to persistent insulin secretion, and therefore you get transient hypoglycemia. The other is there is a decrease of energy supply. There isn't energy supply. If you're born extremely preterm or your growth restricted, then you haven't got the energy supply to replace what mother was giving you. The other, if there is stress, asphyxia, sepsis, or if you are not feeding the baby, then your stores, whichever the stores the baby has, are depleted. So that's another reason. Or the demand is very high. Hyperthermia, sepsis, polycythemia, etc. And a very small percentage have an endocrine or metabolic problem. We tend to think that hypoglycemia is mainly an endocrine and metabolic problem. It is not so. What is the problem is mainly this and these three. Now let's talk about the transient hypoglycemia. What happens when a baby is born? The glucose level goes down for first 4 hours and then gradually starts to rise. And in the first 4 hours, look at the level, 1.7 to 1.5. And that's acceptable. It's only after 4 hours the levels go above 2 to 2.6, which is taken as a cutoff by many. But when it is low at 1.7 or 1.5, only 40% of infants are symptomatic. 60% you don't even know that they have hypoglycemia. So the question is, what about at this level? If you were to do a blood sugar and you found it at 1.7 or 1.5, Junaid, will you treat it? The question, should we treat hypoglycemia in asymptomatic newborn during this period? Big question. Quite often people jump to glucose. Quite often people do not jump to glucose. That's a debate which we can have in discussion if you want to. But this is a very important point, that you have a nadir of blood glucose, which is only 40% are symptomatic. Now, the next 3 slides are from textbooks. I will not spend much time. The signs and main risk factors are well known, but only 30% of these babies have risk factors. These are very well known, and they may be the risk factors, and if the baby is ill or stressed, you know that these babies may get hypoglycemic, and these babies are at risk of significant hypoglycemia. The next slide is, of course, the symptoms are non-specific. They can jitter, they can have convulsions, they have apnea or cyanosis, hypertonia or feeding difficulties, but we as clinicians are unable to diagnose that or differentiate it from sepsis or any other condition. So the problem is, therefore, there is an ongoing debate about screening. But the question is, who should we screen? Every baby? Every preterm baby? How should we screen? Intermittently doing blood sugar, or put a continuous screening monitor? And for how long should we screen? Just for the first 2 hours, or first 4 hours, or first 12 hours, or first 48 hours? We don't know. Intermittent screening, if you were to do repeated blood tests, it only detects 50% of hypoglycemia. Not good enough. What about continuous screening? It also detects asymptomatic hypoglycemia. So you may start treatment, which can cause harm. So both of them are not clearly defined, and where it's not very clear how one should screen. So what are the modalities available to us? What are the measurement challenges? I showed you that clinical diagnosis is only possible, or the specificity and sensitivity goes up when the blood sugar is well down in the boots. It's about 1.7, 1.5. Anything which you take as a cutoff, you are unable to diagnose clinically. Quite often we measure with a glucometer on the bedside, but it depends what glucometer you're using, because the glucometers use different methodology. And also, if you don't calibrate the glucometer, there is a drift, and the drift may be quite high, up to 5 milligram per deciliter. And therefore, you may get an erroneous result using the glucometers. And if there is polycythemia, the hematocrit is high, that's even worse. It's very difficult to do that. What about laboratory? It depends on what your laboratory is measuring, whether in the blood, serum, venous or arterial sample. There's a difference between 5 and 15%. Can you imagine how difficult it makes you to define what hypoglycemia is when there is a 15% difference? And how and when you will start treatment? Difficult. And same thing applies for continuous glucose monitoring. When you even do continuous glucose monitoring, there is a drift, and you need to calibrate it from time to time. So neither of the methods are ideal. And the current hypoglycemic screening guidelines fail to meet many of the necessary principles. And I have put this phrase, quite often neonatologists, if there is a baby with hypoglycemia, they throw the book on the baby. They do hundreds of tests. But I think development of precision medicine should limit this. You should really think why you're doing what you're doing. Do you need so much blood, so many tests to just diagnose or clarify hypoglycemia? The metabolic and endocrine event is, as I showed you, just the tip of the iceberg. It is not the most common, but we tend to do that. I don't know why we do that. The problem we have is, how do we detect neuroglycopenia? Because it's neuroglycopenia which affects the parieto-occipital cortex of the brain. How many of you know that one of the major causes of visual disturbance and visual pathology is hypoglycemia? We think about oxygen, we think about ROP with oxygen, but low blood sugar and equally high blood sugar are both responsible for developing ROP. It's not that simple. So what is the best method? Recently, only very recently, about I think just 2 years ago, the magnetic resonance complication, MAGIC, using a computerized magnetic resonance, you can detect hypoglycemic encephalopathy. The more orange the color, the more the brain is affected. Now, that is not available most places, but that's one way of diagnosing it early and accurately. The next question is guidelines for management. And I am almost certain that all of you have guidelines for management in your unit. Are they applicable? Does one shoe fit all? Let us put a question. Should we treat a hypoglycemic infant of diabetic mother who has a high insulin the same way we treat a baby with who's growth restricted and has hypoglycemia, because that baby has low glucose reserve? But we treat them all the same without understanding the basic pathophysiology, without understanding physiology. So you get hypoglycemia, you don't care whether it is high insulin or low glucose reserve, you start treating it. And the treatment should be different. This baby should be given more glucose reserve. This baby has high insulin should be given to lower the insulin. So the difference, there's a huge difference. There is no consensus. We tend to use, it is our policy, but your policy may be different. We tend to use a red light, traffic light signal diabetes. But we all agree that baby who is hypoglycemic should be breastfed. and breastfed and breastfed. We all agree that. But for the blood sugar to rise on breastfeeding, the breastfeeding must be at least 25 minutes or more. The blood sugar doesn't rise immediately. It rises slowly and reaches a peak at about 30 minutes. So if you're breastfeeding a baby, the baby must be breastfed for 25 to 30 minutes. But we also treat them with dextrose gel, 40% quick action, oral sucrose, 24% delayed action. And yes, it raises your blood sugar. But does it affect on the long term? No. The meta-analysis is that giving gel, whether you use 40% or 24%, it has no impact on long-term outcome. What are the other strategies? I'm so delighted to see Professor Bhatt. MashaAllah, absolutely delighted to see him. Assalamu alaikum, sir. Delighted to see you. The other strategies, which I'm sure in the workshop they will teach you, is intravenous dextrose. But remember, when you give a bolus, the brain sugar rises very rapidly, and that may produce toxic, stressful elements, and that may be harmful to the brain. So do not use repeated boluses. They should be avoided. You can give glucagon if the energy reserves are less. You can use steroids, but I know that in the breakout session, they will be talking about that. There is the other variety of hypoglycemia, persistent or resistant, or some people call it pathological hypoglycemia. This is the small tip of the triangle pyramid I showed you. I don't know why this, you're getting black. Right. There is no consensus on definition. There is no consensus on management. And I hope in the breakout session, they'll be able to tell you that. It is in these babies that you require an algorithm to how to diagnose them. But there's a very small percentage, but people tend to throw the book on every baby. And of course, before you go into this algorithm, you must take all those samples to be very precise. So if I could summarize about hypoglycemia, remember whole blood glucose is lower than plasma by 15%, and that may affect your management. Maintain oral feeding, do breastfeeding, but at least 25 to 30 minutes. Avoid multiple boluses because it will harm the brain, and continuous infusion after one bolus is what is required. Outcome. Robust studies have not shown asymptomatic hypoglycemia has any impact on neurodevelopment. So if you have a baby whom you have, whatever number you have chosen, and the baby is hypoglycemic but asymptomatic, that is not likely to have a long-term effect. But of course, symptomatic hypoglycemia is a medical emergency. You should treat it. Long-lasting hypoglycemia is significant neurosensory impairment. Hypoglycemic seizures, whatever level, at whatever level that happens, causes global white matter injury. Let me finish off with a few slides on hyperglycemia. Most neonatologists think hyperglycemia is a stress response. Stress because of sepsis, stress because of anything else. It is not. It is not a benign stress, but a marker of and mediator of illness. Persistent hyperglycemia is associated with mortality, IVH, ROP, BPD, and sepsis. Now, we talk about huge amount of literature on BPD. How many of you discuss blood sugar levels when you're discussing BPD? Yeah, ROP, I'll show you in a minute. Observational studies show worse outcome when the glucose is high, but the casualty, whether it causes the harm, is not known. Our operational definition, as I showed you earlier. What are the causes of hypoglycemia? Increased production of glucose or decreased production of insulin. And these you will find in any textbook. Again, you will find this in any textbook. who are the babies at risk of hyperglycemia. These are listed very clearly in most textbooks. And the signs and symptoms of hyperglycemia are also documented in textbooks. So I don't want to go there. And to diagnose it, you will either do insulin levels or the glucagon challenge test. The question then comes, how do you manage hyperglycemia? This is controversial. Whether you should manage it by reducing the glucose intake or whether you should start insulin or treat it with insulin. There are pros and cons. Pros and cons. Pros and cons with each one of them. The answer, evidence is mixed and no large definitive RCTs are available. So we don't know which is a better way of treatment. But be wary of complications of insulin in extremely preterm infants. We know that insulin itself by itself is toxic to the neurons. So it is very careful. We have to be very careful. And of course, as I said, hyperglycemia causes ROP, and I am very, very disturbed that the incidence of ROP in Pakistan is rising, and it's now up to 32 to 35%. It is not only oxygen, but it's the management of blood sugar as well that causes ROP. There is no difference in the growth parameters. They grow slowly, they grow shorter, whether you're using the lower cutoff or the higher cutoff. So I'd like to end with some knowledge gaps. I think what is important is glycemic stability matters more than absolute numbers. We need for unified consensus definition of dysglycemia, which we don't have. Consensus on thresholds for treatment, when should we start treating? Who and how to screen and for how long? Value of treating asymptomatic hypoglycemia, how to detect neuroglycemia. Neuroradiology is now coming up. Safety of insulin therapy in extremely premature infants. So the takeaway message, ladies and gentlemen, is very simple. Dysglycemia is a disorder of regulation, not a single number, not a single value. Numbers are tools, not truths. Stability, context, and the clinical picture matters more than threshold. And this is what I have added. This is my statement. Perhaps the most dangerous number is the one we trust too much. Because we have in our guideline, this is the number, and this is what we should follow. Maybe that number is not quite what we should have. And Professor General Saab, this is for you. जो कुछ है सामने वो कतरा है दरिया का अभी तो इल्म के समंदर में जहाँ बाकी है. And I'd like to end it with these are my references, and you will find them in our textbook. It is all available.